we'll look forward to working with you guys on Friday. Okay, thank you. Uday, over to you.
Thank you. Can everybody hear me all right?
Yeah.
Thank you. So again, good morning, everyone. Thank you for joining today's grant rounds. The topic that I choose today is a language barrier in healthcare and in specific urology. So this some couple reasons that I chose this topic. The first one, the issue is becoming increasingly important in the US as the patient population grows in low English proficiency. And the population grows more linguistically diverse. And as our own institutions, UF serves a large number of patients with limited English proficiency. It is so common for us. And the language barriers are not just about miscommunication, so they are a patient safety issue. Misunderstandings can directly affect diagnosis, adherence to management, and outcomes. Moreover, this is not a static problem. It's growing every year as migration patterns and demographics diversely expand. Um, some basic understanding about this language barriers in the U.S. Limited English proficiency, or LEP, is defined by the Department of Justice to be individuals who do not speak English as their primary language and who have limited ability to read, speak, or write, and understand English. According to the U.S. Census Bureau, 1 in 5 people speaks a language other than English at home, and about 30% of them have limited English proficiency, or LEP. That's more than 25 plus million people in the US with the LEP individuals. And this is still growing, nearly 1 million more than a decade ago. Interestingly, while 40% of US physicians speak another language than English, only about 10% use it clinically on a daily basis. So this mismatch does highlight how the barriers still exist and it limits the effective language concordant care. Here are some of the most common first languages spoken among individuals with LEP. As you can see, Spanish is by far the most prevalent. It accounts for roughly 60% of all LEPs, representing about 16 million people in the US. The next largest groups are Chinese, still big, around 2.3 million, followed by Vietnamese, Tagalog, and Arabic. So while there's important linguist diversity, the Spanish-speaking LEP population dominates, which has significant implications in healthcare as well. This map illustrates the proportion of population in each state estimated to have LEP. The darker the color, the blue color, the higher the percentage of the individuals with LEP. As you can see here, Florida stand out with the darkest blue, indicating that the over 10% of the state's population is considered LEP. So overall, especially here in Florida, we're working with a large and growing population that faces language barriers. Another important implications of limited of LEP in healthcare is insurance coverage. These graphs shows the proportion of people covered by private insurance, Medicare, or other public programs, and those who are uninsured. This is 2021 data. And among English proficiency population individuals, around 60 to 70% had private insurance, 24 covered by Medicare or other public programs, and fewer than 10% were uninsured. However, when it comes to LAP, the proportion of uninsured individuals increases dramatically to nearly 30%. And when we further break these data down by race and ethnicity, we see striking differences. Among Hispanic patients with LAP, only about 35% here have private insurance, while nearly 37% are uninsured. This pattern is not consistent across all LAPs. So these are all LAPs, but as you can see here, when it comes to Asian population, for example, or even white population, the number of patients who are uninsured is somewhere between, for Asians, 10%, white 16%. So even within the LAP community, there is significant diversity in socioeconomic and insurance status. Unfortunately, the Hispanic population, which makes up the largest proportion of LAP individuals, which we care for daily, is disproportionately affected by lack of coverage and access to healthcare resources. So based on these data, Florida has one of the highest proportions of individuals with limited English proficiency, and healthcare coverage among this group tends to be more limited and challenging. As a safety net hospital, we are especially like to care for these patients on a daily basis. Therefore, it's fair to say that understanding the unique challenges involved in providing care for LAP population is not just important, it's essential. Now, what exact impact do language barriers have on patient safety and outcomes? Studies have shown that patients with LAP experience higher hospital readmissions, particularly within 30 days of discharge. That study suggests that one major reason is that these patients are less likely to receive or fully understand discharge instructions in the language they can understand. Which does affect their ability to manage care at home by themselves. Similarly, research has demonstrated higher rates of misdiagnosis and medical errors among LAP patients. This includes medication errors and even procedure errors. And what is more concerning is that when adverse events occur, these tend to be more serious. In fact, 49% of adverse events among LAP patients resulted in actual physical harm, compared with about 30% in English proficient populations. This gap is striking, and it's estimated that majority of these events are directly related to communication errors. Also, previous studies have shown that language barriers negatively affect both patient satisfaction and adherence to treatment and follow-up. Patients for language concordant with their providers, meaning that they share the same primary language, report higher satisfaction and better engagement with care in systemic review In contrast, LEP patients are less likely to attend follow-up visits after follow-up hospital discharge, as demonstrated in several retrospective cohort studies and also, again, systematic review. Moreover, multiple studies across have reported poor adherence to chronic medications, especially in internal medicine literatures. That conditions such as hypertension, diabetes, and so on. Another important perspective is from the physician side. It goes without saying that physicians or providers trained in the United States receive almost full on their medical education and clinical training in English. Now, there are also many international IMGs here, including myself, who completed their education and training, or at least part of it, outside the US. So in theory, physicians should be better able to communicate complex medical concepts in the language which they were trained. However, it is important to note that around 40% of countries outside the US and Canada still use English as the primary language of medical education. This means that large proportion of IMGs working in the US have also received their almost entire education in English. So as a result, even bilingual or multilingual providers, we do have a lot of providers like this here as well, may sometimes struggle to convey detailed explanations or nuanced discussions in the patient's first language, particularly when it comes to sensitive or technical medical topics. These following slides, I'd like to move on to some recent studies that explore the relationship between English proficiency and urologic diseases. The first example focuses on the PSA screening. As you can see on this graph, among patients with very good English proficiency, the one in the very far left, about 20% have never undergone PSA screening, meaning that roughly 80% remaining this red, green, and yellow have at least had one PSA test in the past. And however, as English proficiency declines, as you go to the right-hand side, the proportion of patients who have never been screened for PSA rises dramatically. And it reaches over 30% here, and even over 40% in some groups. Well, now there is still ongoing debate about the overall benefit of PSA screening as a society, but this finding may suggest that patients with LEP have reduced access to preventive screening, or may be less likely to be counseled about it by their primary care providers. The next study comes from the New Zealand and Australia, that which examined the patterns of prostate cancer presentations among patients with different levels of English use. According to this study, there were significant differences in both the median PSA and PSA density between well English speaking and non-well English. So the bottom line is patients with LEP tended to present with higher PSA. And the second finding was that greater proportion of LEP patients are required, larger proportion of LEPs, which means that patients did need an interpreter. presented with ISAP grade group 2 or higher disease, as you can see here. Patients who did not need interpreter, there was higher proportion of patients that fell within the grade group 1. This may suggest that LEP patients experience diagnostic delays, possible diagnostic delays. When looking at management patterns as well, additional differences were observed between good English speaking and not so well English speaking populations. As you can see here, the rate of active surveillance chosen as a management was significantly higher among English speaking patients, whereas the androgen deprivation therapy, ADT, as an initial management approach were more common among English speaking patients. Now, this could certainly be influenced by factors such as tumor grade, a grade group, or other clinical characteristics not fully accounted for in this study. However, it may also reflect that both patients and providers feel less confident or comfortable pursuing active surveillance in LEP, because this obviously requires clear communications, shared decision making, and consistent follow-up, and all of which can be challenging when language barriers exist. The third study is a very recent publication, just released in this month in Urology Oncology, and examines differences in post-operative communication patterns between LEP and English proficient patients following radical cystectomy. The outcomes are kind of like nuanced and a little bit difficult to understand, but the key findings was that English-speaking patients communicated more often with their care team after surgery. 6 times they called in 6 more than the LAPs. And the English-speaking population were more likely to initiate communication on their own, whereas the LAP patients often rely on family members to communicate on their behalf. So as a result, English proficient patients were more likely to avoid possible unnecessarily in-person office visit, and as they could be reassured or managed through remote communication. But in contrast, LEP patients required more in-person follow-up visit, and follow-up visits and interventions. Although the study found no significant differences in overall healthcare utilization patterns between the two groups, it clearly highlights that LEP patients are less likely to use convenient communication tools, even during such critical period as post-operative phase after radical cystectomy. Now that we've discussed the clinical and patient satisfaction aspects, let's look at the economic impact of language barriers in healthcare. Inefficient communication clearly exists, as we can see, and it has measurable consequences when providers spend the same amount of time on history taking and physical exams, but must rely on interpreters. Less information is often gathered, and this can lead to ordering more tests, sometimes unnecessarily, such as, well, this includes ultrasounds, CAT scans, X-rays, UAs, and urology settings. And all of these adds additional costs to healthcare systems. On top of that, interpretation and translation services themselves are not free. For example, Video interpreter services typically cost $2 to $4 per minute, and telephone interpretation runs about $1 to $3 per minute. While these numbers may not seem very big individually, they accumulate quickly and create a substantial financial burden for healthcare institutions. Furthermore, federal regulations prohibit hospitals from billing patients directly for these services, meaning these costs must be absorbed by healthcare systems. Lastly, there are legal implications as well. Miscommunications can lead to medical errors or even malpractice claims, adding yet another layer of risk and cost, and also some burden in terms of mental stress to providers and healthcare staffs, and costs associated with inadequate to staffs. So policymakers have taken steps to address language barriers in healthcare. The most important and well-known framework is Title VI of Civil Rights Act of 1964, which prohibits discrimination based on national origin. And over time, U.S. courts have interpreted national origin to include language access, meaning that failure to provide appropriate language services can constitute discrimination. And as a result, any healthcare program or institution receiving federal funding, such as Medicare or Medicaid reimbursement, is legally required to ensure meaningful access for patients with limited English proficiency. In more detail, it requires that entities receiving federal funds provide meaningful access. This includes offering oral interpretation and written translation services, both of which must be provided free of charge to the patients, as I explained earlier. In addition, vital documents such as consent forms, discharge instructions, or treatment information should be translated into languages that non-English speaking patients can understand when necessary. It is important to note that the regulation specifies should be translated, and leaving some flexibility in implementation depending on the context and resources. Lastly, healthcare organizations are also required to post clear notices within their clinics or facilities to inform patients that these language services are available. We can see these signs and pretty much anywhere in the clinic settings in the UF as well. Looking at some of the tools and resources, actual tools and resources that have been implemented to address language barriers in healthcare. The most obvious one is interpreter services. Previous studies suggest that although interpreter services carry a cost, these expenses may be offset by, for example, shorter hospital stays, improved preventive care, and fewer emergency department visits, ultimately leading to overall financial benefits for healthcare system as well. However, the cost burden still exists, especially for institutions with a large LEP population. And obviously that includes UF. In terms of technology, some EHR system, including Epic, have developed multilingual patient portals that allow patients to view test results or educational materials in their preferred language. I'm not certain at this point whether the function is fully available at UF, but it is true that some health networks have started to adopt it. And beyond the language alone, there's also a growing recognition that cultural understanding plays a critical role in effective communication. Experts have emphasized that culture barriers, not just linguistics, often prevent patients from receiving the best possible care. So, to address this, many institutions and training programs have introduced cultural competency education for providers. And one of the most common initiatives is Spanish language training in U.S. medical schools. Since Spanish speakers represent about 60% of all LEP patients, again, this focus makes sense. However, a national survey found that only 17% of these programs meet basic proficiency standards, obviously indicating room for improvement. Another promising option is the use of online medical Spanish courses, some of which now offer CME credits, for example, through the American Academy of Physical Assistants. So may not be through the AME, but there are some entities that are utilizing these stuffs. And again, finally, as we move into the future, we will likely see AI-assisted translation tools will play a larger role. And while these have great potential to enhance accessibility, the major challenges will be to ensure their accuracy, reliability, and also the security of patient data, which is still preventing it from widespread implementation into healthcare systems. So I kind of like, there were some cases that I prepared some like model cases, like real world cases. So to make this a little bit more clear. So the first case is more of a general urology case. I think about 67-year-old Vietnamese only speaking man presenting to ED with urinary retention. Possibly, it was determined that it's possibly due to BPH. Was put in the catheter. The surgeon instructions were only in English, so he missed his follow-up visit and represented with hematuria to the ED. The catheter was exchanged, but he came again to the ED, now with infection, fever, and catheter malfunction. He had to undergo CAT scan, determined that he has febrile UTI, was admitted to the hospital. This kind of cascade shows how inadequate communication directly translates into repeated admission and higher morbidity. Another possible case, this is a little bit revised, but more based on the real case. 70-year-old male with Spanish speaking only background was diagnosed as muscle invasive bladder cancer and grade group 2 prostate cancer. In the clinic, his situation was discussed with patient and his daughter in presence, and that daughter stepped in to serve as a translator. And after a thorough discussion, at least thorough, interpreted by the provider, patients chose to undergo radical surgery, which means radical sister prostatectomy. But the family later realized that they had not fully understood the need for a stoma, and his son was not present in the clinic during the discussion, called in the day before surgery. requesting to postpone the case so that they can have further discussion with the provider. So imagine, let's say by this time, 3-4 weeks will probably have passed, resulting in a delay of providing care in such a highly aggressive disease. And also it will turn into underutilization of our block time from the healthcare, from the provider's point of view. So here, despite various initiatives to close the language gaps or gaps in language in healthcare, there are many persistent challenges. First, enforcement of language access regulation is so inconsistent. While the federal law requires healthcare providers to offer language services to patients with for patients with LEP, many institutions, especially private practices, private clinics, and rural areas don't have clear protocols, staff training, or quality insurance monitoring system. And also access, if they have access, the actual access to qualified medical interpreters is often limited. As a result, family members or untrained staff are often used, which can seriously compromise the quality and accuracy of communication. Studies have shown that when professional medical interpreters are used, patients report higher satisfaction and understanding of their condition. And it will result in better understanding of care plans and greater trust in healthcare system. In addition to this, there are problems with the health literacy within the LEP population. Also, educational materials and patient portals. Although there are some new things available out there, it's still only available in English in many settings. So this does add to the limitations. And when it comes to high stakes clinical areas such as emergency department visits, certain oncology settings, and the settings of mental health or psychiatry, language support is often inadequate, or even when it's provided, it is delayed and it's too late. Lastly, I would like to highlight some unique challenges specific to urology when it comes to language and communication barriers. The organs and body parts we deal with in our service are highly sensitive, personal, and also private. Because of this, the presence of a third party, especially when it comes to an interpreter of the opposite gender or someone unfamiliar, can make patients feel uncomfortable or even embarrassed and may inhibit them from disclosing key symptoms such as sexual dysfunctions, incontinence, or genital pain. Another important aspect is that complexity and multidimensional nature of urologic diseases. Many conditions require value-based, quality of life-centered decision-making. We can take prostate cancer management, for example. When we discuss radical prostatectomy, versus active surveillance or radiation therapy. We are essentially balancing oncologic control with functional preservation. Even for English proficient patients, this can be difficult to fully understand. From both my own experience and previous literatures, we know that explaining the nuance logic behind options like active surveillance requires very precise empathy and patient-centered communication. Now, when language barriers are added to this already very complex discussion, it becomes extremely challenging to convey the subtleness of risk, benefit, and trade-offs. And beyond language, cultural differences also shape how patients perceive illness, sexuality, and decision-making authority. So this puts further complicating issues on how we deliver truly patients' care in the setting of urology practice. So to summarize, in Florida and in UF in particular, we're in a very language vulnerable region. And importantly, language barriers is not merely a communication gap, but it is a patient safety issue. And in urology, unique challenges are often faced. We need to continue efforts, both from clinical and possibly administrative perspectives, to improve language and culturally competitive patient care. Thank you for your kind attention. And if anybody have any questions or comments, we'll welcome that. Thank you.
Yudai, this is Robert Marino. Thank you very much for presenting this. I think it's a timely subject, and I like the data that you presented. I think that one of the, we spend a lot of resources. These interpreters that we have that we spend a lot of money on that, and having the online interpreters that can, on a tablet that comes into the room, and most of the time they can find somebody who speaks the patient's language. Occasionally we have a few patients that they can't seem to find an interpreter. Maybe they have a special dialect of the language that they use. In addition to that, I occasionally run into a patient who, even though they have a good command of English, better than our command of their native language, they insist that the interview be conducted in their native language with an interpreter, which automatically slows down the process.
Right.
Fortunately, this is a minority of patients, but I do run into that occasionally. In terms of one of the resources that I see as the most fruitful, we also are in an age where most people are able to have either themselves or somebody in their family handle, I wouldn't say SMS, but anyway, like text messaging or messages that are electronic. And so for us, the main tool that we have that is compatible with medical care is the MyUF Health application, otherwise known as MyChart.
Mm-hmm.
So if I'd had my choice, every patient that I see would have a designation in the chart as to who's going to handle their MyChart account, not that whether they're going to have a MyChart account or not. Yes, there are some occasional patients who insist that object to having a MyChart account, but that's a great minority.
Mm-hmm.
And the reason this is important is because if they cannot handle it, sometimes somebody in the family can be their spokesman through the MyChart account. And they sometimes have more command of the electronics, and they have more command of the English language. In addition, I do have patients who respond. They know that I speak Spanish, and so they send me messages in Spanish. I routinely respond. When I respond to them, I routinely respond to them in English, trying to address a little bit the background of the question that they asked, so that the message can, number one, they can use Google Translate or other translating online services to translate my English language into their native language. So even though it is Spanish, I'm not going to respond to them in Spanish. Number two, the rest of the members of my team have will be able to read that message later and understand what's going on, because otherwise, if we start a conversation in Spanish, there it may be limited to the team and put them in a burden. So my hope, if I had my choice, every patient coming to the practice would be asked, who's going to handle their MyChart account, and it would be established even before they come to see us, so that even while they're in my presence and they're in the first visit, I can send them a message and it'll flash on their phone, and we can establish a confidence in them that yes, we will be accessible to them, and encourage them to use that. So those are just a few thoughts.
Thank you very much. I mean, yeah, the speech, as I myself doesn't have a very good use or pretty much zero use of Spanish, I always struggle with a large population that we have here. I think the other challenge is that I hate to say this, but the proportion of these LEP patients have relatively lower on the lower side when it comes to medical literacy as well, or maybe over educational status. So it is very hard as a baseline to understand the very complex aspects of their condition. So I don't have like a clear way of solving this, but like being able to like probably what you said, like involving multiple people within the family or relatives that may have better use of English might be one of the ways that we can utilize. So thank you.
Yudai, thank you for putting this talk together. I had a question for, I guess, the faculty in the group. You mentioned the discharge instructions that patients receive. I typically go on Google Translate and I will copy and paste those discharge instructions into the translation window and try to get it translated into their native language, so that it goes in the discharge instructions in both English and whatever their native language is. Sometimes that works well, sometimes it doesn't. It depends on the formatting of the discharge instruction template that's available in Epic, the ones that we routinely use. Is there any utility, or would there be utility for our service to have some of those discharge instructions in, say, some of the more common languages, for instance, Spanish, for some of our more common procedures as an available template within Epic? Is there a way to produce that where we could have kind of these canned discharge instructions, say for a TURP or a TURBT, that says you're going to go home with a catheter, you're going to have it for X amount of days, we're going to see you back in clinic to remove it, or say for a stone, you're going home with a stent in, that stent's going to be on strings, remove the stent in X amount of days. Is that available to us, or could we acquire that?
I feel I can comment on that, Tommy. Thank you for bringing that up. Epic does have, when we fill out the after visit summary, ABS, and we put there the procedure, or that they oftentimes they have, first of all, the instructions, and second of all, oftentimes in another language. The most common one that they have is Spanish, and I use that extensively when I see patients that are Spanish speaking, or if I can find another language. But I think your effort to go through Google Translate, and in addition to that, translate it, it's a commendable thing. And yes, we cannot check the accuracy of that Google Translate. There may be some mistakes there, but I think that overall one comes out ahead if you meet them halfway and it's better than not having it or providing it to them in English and then asking them to go through the effort of trying to translate that with their own tools. So I don't know if that helps, but I think Epic does make an effort on that.
Dr. Mano, thank you very much. Dr. Mandy, go ahead, sir.
I just thank you so much for presenting this very interesting topic and really timely topic too. And Tommy, also for your comment. I'm probably going to talk about again today about people coming back to the emergency room because we're working on those quality metrics. I just wonder whether the foreign language has any effect on this also. I mean that's a great idea. Maybe Dr. Costa can help us with. Getting these instructions in at least Spanish. That would be amazing to be able to do that and try to give the information to the patients at discharge better. So that's a great thought. And I think this is something that we should work on here in the department as our society changes over time. Great talk and comments. Thanks.
Thank you, Dr. Bannigan. I also would like to echo Tommy's suggestion. Dr. Balaji or Bill, is there any chance we can try to create the Spanish version or version of discharge instructions with the help of some very Spanish experts for very basic or very commonly performed procedures, because I think the after discharge ED visits in these populations are a pretty big issue.
I think we could submit something to the translation department here.
Bill, would you be able to respond?
Yeah, I'm not familiar with how to do that, but I do think it's something we should look into, and I'm happy to take the lead on that. My guess would be is we would have to use some sort of certified company or translating company to get these documents translated, and then from there we would have to work with Epic to get them loaded into Epic. But I don't see with today's technology and today's world we live in, I don't see why that wouldn't be possible.
Yeah, if that can be, if that's possible, I think that's optimal because what Tommy or maybe some of us are doing, like using the AI or Google Translator, pretty much the same thing, to translate. And I think it does work in very good proportion of occasions, but at the same time, it wouldn't really be us who has to take the responsibility of the accuracy and the content. So if we have a template that we can all agree on, that'll be more preferable.
At my prior institution, for instance, with research protocols, the university had a service by which a research consent and research protocol could be translated into a language of the investigator's choice. And it was typically Spanish was the biggest one that we most commonly used. So perhaps the University of Florida has that resource available in one of their research departments, and we could utilize that to translate at least some of our more common procedures into, like Dr. Bandic was saying, that even if we just had it in Spanish, I think that would be a tremendous advantage.
And I think there's an effort going around, like for example, I now have Spanish bladder cancer network books, educational books you see I hand out to people with bladder cancer. And so now we do have Spanish books too. So it's a kind of an effort, I think, that's going around in the country now to better inform the people who cannot speak English. Thanks.
Now,
I was going to say there actually is on the UF Health bridge, there's a translation services link, and we can submit documents to have the UF interpreter services translate. So it's
excellent. So that was exactly what I was talking about. I'm sure that aspect, I'm sure that service is available through the university, because the university has too many interests in kind of global populations and research investigations to not have something like that. Thank you, Hunter.
Yudai, a practical question. So, if we go into a patient whose first language is not in a room with the patient first language English, and there is a family member who's willing to interpret, should we utilize the family member or should we call for a professional interpreter?
So, like, I think, like the textbook answer will be to call in the interpreter. Now, I do believe it depends on the patient or the situation to situation basis. So, I would say, as someone who is aspiring and training to be in the field of oncology, any oncology related discussion should be held under professional interpretation. But in some other settings, it may be reasonable, okay, to use family member as interpreter. That's my answer. But maybe somebody else or have some other opinion.
Well, I think they're really scrutinizing, our consents now. And I think it's if we have a Spanish speaking person, I think we need an interpreter and have that co-signed that this was a Spanish English interpreter for that consent because they're really looking us, really scrutinizing us more and more with the consents. So I think we should do that, have a interpreter in the room for consents.
How about in a regular clinic consultation, Mark? If we have a family member willing and able to translate, should you still get a professional interpreter?
I think so. We can, it's kind of a hassle here in clinic to get that out, and we use Recess a lot for her interpretation abilities. But I think so. I think we probably should be going to an interpreter, a standard, video interpreter.
Yeah, the interpreter services are a lot more accessible now than they used to be because of the video or audio services we have. I remember 20 years ago, one clinic I went into, a job at UMass. I saw 12 patients or so in the morning. And what was striking at the end of the clinic was there was not a single English speaking patient. And everybody from Arabic to Russian to Spanish. I mean, the diversity I saw in that clinic was very striking. And every one of them, we tried to get an interpreter in the room. And some rare languages, like Arabic, we had to call over the phone. But there was always a Spanish interpreter in the clinic, in person. And that interpreter, of course, was busy. And when you're relying on one person to be there, there's always some delay for them to arrive and so on and so forth. But with the newer technology, it's a little bit more accessible. My practice has varied. I think if the family member is willing and able, I think there is one advantage to having a family member. They know the person and they can communicate in a way that the person understands, rather than getting a third person in the room was very professional, but may not know the patient. But there's also the downside to it. And if I use a family member, then I give them very clear instruction that they have to translate what we are saying verbatim to the patient. And I pause till every sentence is translated instead of them assimilating everything and then summarizing to the patient, because that can sometimes lead to communication gaps. But, honestly, I'm not really sure what the best way is, but consent and things, we probably need to have a professional interpreter. Yes.
Yeah, like I personally find that as a use of our resources like human resource utilization, like dealing with patients who need interpretation it has a lot of downside. It can be helped, but it is a major challenge because I typically spend almost twice as much as time. So yeah, that was the main reason why I brought this topic, although I couldn't find a very clear solution or answer.
Yeah, I think several of us on this call were multilingual, could probably relate to this. There is something called the translation gap, and this is inherent in languages. For example, certain things that I can think and say in my mother tongue, it's very hard for me to translate in English. And because a lot of medical developments are in the English language, a lot of other languages do not have synonymous words that mean exactly the same thing we are trying to say in English. So there are some inherent limitations in human languages, and that can cause some challenges as well. And the problem is, if we are translating it into another language that I don't know at all, then it's even more complicated, because I'm not sure the extent of this translation gap and the inherent limitations in these languages. So there's inevitably there's got to be some gap there, and some limitation in this form of communication. So. Okay. Thank you. The very timely talk. Any other questions or comments? Okay, Hunter has put a link on our chat for anybody interested in these translating services. Okay. If none else, we'll stop here, and thank you, Yudai. Guys, have a great week. Thank you.
Thank you, everybody.
Thank you.